Good evening and welcome to the Society of Skeletal Radiology Resident Education Club webinar. I'm Kirk Davis from the University of Virginia, and I'll be serving as moderator this evening. And it's my pleasure to introduce the speaker for our webinar, Dr. Pamela Walsh. Pam is an assistant professor of radiology at Northwell Health Zucker School of Medicine in New York, and she's associate chief of the MSK Radiology Division there. She completed her residency at Northwell and her MSK fellowship at NYU Langone, and she's currently chair of the SSR Standards and Guidelines Committee. Her research interests include trauma and postoperative imaging, and she received the SSR ISS Award in 2023 for her research in utilization of CT and diagnosis of occult intertrochanteric hip fractures, which is germane to tonight's topic. And I'm really looking forward to her talk on hip and proximal femur fractures.
So much. So I just want to say thank you to the SSR for having me. I want to thank Mike and Patrick from our Veritas team for this being a smooth production. And Dr. Davis, I'm so excited that you're going to be moderating this session. So we'll get started. I'm going to be speaking on hip and proximal femoral fractures. And so for the goals of this talk, we're going to look at hip fractures and what we can do to improve detection of fractures, as well as how should we characterize them. So first, we'll take a look at some hip fundamentals with regards to X-ray. And then our patient population that we're going to focus on is going to be an elderly patient who comes in with a low energy trauma, such as a fall. So we'll focus on intracapsular and extracapsular fractures. We'll do a little bit of a deep dive into intertrochanteric fractures, and then we'll take a look at pathologic fractures. So here's a bit of background on hip fractures, basically saying that they're not uncommon and the incidence of hip fractures are increasing, and there's a bit of an equal distribution of femoral neck fractures and intertrochanteric fractures, and these are going to make up the majority of our proximal femoral fractures. So essentially, whether you're a musculoskeletal radiologist or any other radiologist that looks at imaging that includes the hip in the field of view, you will see hip fractures. So let's start with our first question. So we have this X-ray here, and say the ER calls up and asks, what additional imaging should we do aside from this X-ray? Great. Okay, so we're a little split. So for this X-ray, we can see that there's a fracture here. And ideally, in that scenario, we want to try to not move the hip. So cross-table lateral is going to be our answer. And let's take a look at that. So here's examples of the frog leg view. And you can see with this, we have to flex the knee and externally rotate the hip to get this image. So when you have a patient with a hip fracture, ideally, you don't want to move them into this position, especially if you don't have an orthopedist on standby. And then when we do our cross-table lateral, though, notice that we're keeping this leg straight. And then the X-ray beam, you can kind of see here a little better, is going through the hip. So a cross-table lateral is going to be our ideal orthogonal view when we know that we have a hip fracture, so that we don't potentially displace the fracture any further. So let's look at this cross-table lateral, and where is the asterisk corresponding to with respect to the hip? Is it anterior or posterior, or neither? Okay, excellent. So the majority said posterior, and it is posterior. And then let's take a look at this now. So here's breaking down our cross-table lateral view. And I find what's really helpful is we see the ischial tuberosity outlined here. So that's really helpful in letting us know that this is posterior with regards to the hip. And these can be challenging because it certainly can be painful, difficult to position a patient who's in pain and who potentially can't tolerate lifting their other leg. And then here we have our femoral head contour. Here's our femoral neck. Here's our greater trochanter. And notice our lesser trochanter is a bit posterior. So use that ischial tuberosity to kind of orient yourself to what's going to be posterior. Okay, so let's look at this one. Is this hip internally rotated or externally rotated? Okay, so a little more with internally rotated. So this patient's actually externally rotated. So let's take a look. It's a little counterintuitive, I feel like, this concept. But when we're in external rotation, so you think about when you're laying down, your leg kind of tends to go outward, as we see here. That's going to bring your greater trochanter posterior. So this is actually posteriorly overlying the femoral neck here. And then also notice our lesser trochanter looks really prominent here, and that's a posterior structure that's being brought forward due to that rotation. And if you've done hip arthrograms under fluoroscopy, you'll notice that we try to put the patient's foot slightly internally rotated, such as here. And that's where we have that really nice image where we can see the entirety of the femoral neck nicely. And if you also think about these patients, we learned in med school a shortened and externally rotated hip in these patients that present on their physical exam. That's kind of what we're seeing here with regards to that external rotation component. Okay, so now we have our hip, and let's organize one being the most proximal, our different levels of the femoral neck and extracapsular structures. Okay, perfect. Okay, excellent. So we have our subcapital, which is going to be kind of at that base of the femoral head neck junction, transcervical, which is going to be through the femoral neck, basicervical, that's going to be at the base of the femoral neck going as it junctions with the trochanters, and then intertrochanteric. And I have this blue line drawn around these three because these are all intracapsular fractures. And what's helpful to prove that is looking at a hip arthrogram. So you can see this is injected contrast here, and you can see down here this contrast is outlying portions of the capsule going all the way down to the basicervical region. And we can see that on our MRI arthrogram as well, how much the capsule extends to surround that basicervical region. So looking at these fractures, you can type in which of these levels do you think would be at highest risk for avascular necrosis if it was fractured? Okay, good. It looks like subcapital is going to be the one. Excellent. So subcapital. So here we have our hip, and the more proximal the fracture is to the femoral head is kind of what I think about with the highest risk of avascular necrosis. And that's going to be because our blood supply is really robust around our intertrochanteric and basicervical region. And then think that these blood vessels have to travel. So as they're going towards the femoral head, they're becoming a bit more attenuated as they course more distally. So when you fracture distally from the vasculature, but closer to the femoral neck, that's where you're going to have more of a higher risk for avascular necrosis and malunion. Okay, so with our subcapital and transcervical fractures, transcervical is going to be another one that we're going to be concerned about avascular necrosis. So when surgeons are thinking about their treatment options, when they have a subcapital or a transcervical fracture, their goal is really to reduce AVN risk. And that could be done with either joint preserving, such as a pin, which we'll see, or using a prosthesis if they're really concerned about a high risk of AVN and malunion. And we have our basicervical and intertrochanteric fractures. Even though basicervical is intracapsular, we saw that image that it's so close to the blood supply that that's going to actually be treated like an intertrochanteric fracture. So with these fractures, we're really concerned about restoring their alignment, and that can be done with extramedullary or intramedullary hardware, which we're going to see. Let's see, is there a fracture here? If so, okay, click on it. You guys are awesome. Okay. So you guys noted that that fracture is at that subcapital region here. So this is that image there. And when we're looking for these fractures, they can be subtle. So what I recommend doing is tracing our cortices and looking for any areas where there's step off. So when we trace this here, we can see that there's all of a sudden this overhang of this cortex here. And we also appreciate that there's a bit of a sclerotic line. So this is a valgus impacted femoral neck fracture. And then here, a little bit of a different morphology with a little bit of varus. When we trace this cortical line here, we can see that there's disruption here as well as some sclerosis and impaction. And this line here is called Shenton's line, which should be a nice smooth line, and we can see that there's disruption there. And while a lot of these fractures are impacted, you also want to make sure you look for lucent lines as well, as in more traditional fractures. And then this is the Garden classification for these subcapital and transcervical fractures. I'm not saying that you have to describe that, say, Garden in your report, but it's important to note why they're classified this way. So our Garden 1 is going to be a valgus impacted or incomplete fracture, which we're seeing here. Our Garden 2 is going to be a complete fracture that's not displaced. And then 3 and 4 are going to be fractures that have displacement. So they're either completely displaced, like in a Garden 3, or completely displaced, as in a Garden 4. So I showed you those images that are just frontal views, but we do need to look at our orthogonals. So here we're looking at our cross-table laterals. Here's a normal cross-table lateral where we see our femoral neck here and then our femoral head here. So there's no displacement here. But on this image, we can see that there's a bit of angulation of the femoral head neck junction here. So this may look not displaced on our frontal view, but when we look at this orthogonal, there is a bit of displacement here. So that's important, and the surgeons really want to look at that, because if there's greater than 20 degrees of tilt or retroversion of the fracture, then they're going to consider that displaced and think about alternative ways to fix that fracture. And then here we can see one that's more obviously displaced. We can see we have our femoral neck here, but then our femoral head is all the way back here. So this is a completely displaced fracture. So this is just looking at those fracture classifications again, using X-ray and CT. So that first one was the case that was our question, our valgus impacted femoral neck fracture. And then here's our Garden 2, which is complete but not displaced. And then here are Garden 3s and 4s. So notice in these that the patient's femur is externally rotated. So as we saw in that initial radiograph, we can see our greater trochanter is overlying that femoral neck, and our lesser trochanter looks really prominent. So you can see that on the CT images here of these fractures. And then when we look at our axial view, we can see that anterior apex angulation. And then notice how that's bringing our greater trochanter posterior, as in these images, correlating to the X-ray. So we can see with that external rotation, that brings your greater trochanter to the back, and then it overlies your femoral neck and brings your lesser trochanter kind of more forward. So here are orthogonal views, and we can see this displacement, how it's angulated, we noted that this is going to be posterior because of our ischial tuberosity, and this is going to be anterior. So we see that anterior apex angulation, and that's going to correspond to this CT image here, how we can see that this one's angulated anteriorly as well. Okay, good. So here's that garden classification. And then when we see different degrees of displacement, that's what the surgeons are going to look at with regards to how they're going to fix these fractures. So we see this fracture here. What do you think is going to be the likely surgical fixation that the surgeon's going to do? Okay, good. So we have a subcapital fracture that's completely displaced. So it's going to be at high risk for a vascular necrosis and malunion because of where the fracture is and because it's displaced. Excellent. So when they're non-displaced, the surgeons can opt for joint preserving hardware, so these cannulated screws. And then when they're displaced and there's that concern for avascular necrosis and non-union, of course, it depends on the patient's activity, comorbidities, and surgeon preference. They're likely to get an arthroplasty, depending hemiarthroplasty versus arthroplasty, depending on a bunch of patient factors and the surgeon's comfort with those procedures. And then here's an example of a fracture where I think it's really just hard to tell, and understandably so. It's externally rotated. This proximal femur is essentially overlying the the femoral head. So we really can't tell, and that's okay. And then here, so we do this sometimes at our institution, and this orthopedists are the ones that are doing this. You can put traction on the leg and then internal rotation to attempt to align the fracture a little better, to reduce it a bit and to more definitively characterize it. So you may see this done as well. So this was that same patient. And after applying traction and internal rotation, we can see that there's better alignment. And then also to note, cross-sectional imaging is certainly appropriate in some scenarios, and there are some fractures that are just occult. Here we can't see it on X-ray, we don't see it on CT, but when the patient had an MRI, this is our T1 image, we can see this hypointense line going through the femoral neck. So there are times when CT and MRI are going to be warranted for the workup of these fractures. So here's an example of a basicervical fracture. These are more rare. And again, these are technically intracapsular, but we're treating them as extracapsular, like intertrochanteric fractures. So when you're calling a basicervical fracture, you want to be sure that you can see a decent part of the femoral neck. I kind of like to see where it flares out a bit more, because you want to have more of that femoral neck, because the fracture is going to occur at the distal aspect of the femoral neck at its junction with the trochanters. And then here's an example of transcervical where, you can see someone potentially wanting to call this basicervical, but look how short that femoral neck is there compared to our basicervical. So that's one helpful way to try to differentiate transcervical versus a basicervical fracture, of how much of the femoral neck is intact there. Okay, and what kind of fracture do we have here? Okay, good. Yeah, so this is a tough one, but this is an intertrochanteric fracture. We'll take a look at those. So intertrochanteric fractures there's quite a bit of classification systems, and I do not want you to memorize these, but I do want you to focus when we're describing intertrochanteric fractures on a couple of features that are important. So that's going to be, is it comminuted or multi-part? Is the lateral cortical wall intact or is it fractured through? And then is the posterior medial cortex fractured, or is it intact? And the posterior medial cortex is in an area where the calcar femorale lives, which is this little dense buttress of bone, and that's an important stabilizer for the hip. So when that's markedly comminuted, then that's a feature of instability, and that kind of helps the surgeon decide, again, what kind of treatment that they're going to do. So here on the left here, we have a intertrochanteric fracture that's not displaced, and it looks like it's in just two parts. And as we go across the screen, we can see that the fractures have more parts. So here's a avulsion of the lesser trochanter, and you can see this has some comminuted parts. So when they're not displaced or kind of a simple two-part fracture, that can be treated with a dynamic hip screw. And then also you can certainly treat it with an intramedullary rod. But as these fractures become more complicated or displaced and comminuted, then we're going to opt for an intramedullary rod for a more stable fixation. So what kind of fracture do we have here? Okay, excellent. So this is a reverse obliquity fracture, and we can tell by the way the fracture line's going. So it's going from the lower outer aspect of the femur, and it's going in an upward fashion across the intertrochanteric region. Our classic intertrochanteric fractures come from up here at the greater trochanter and come down to the lesser troch. So we have that reverse oblique fracture. What kind of hardware do you think the surgeons will use? Okay, excellent. So they're going to use an intramedullary rod because these reverse oblique fractures are unstable. And let's take a look at why. So when they opt to fix with the dynamic hip screw, here's a conventional trochanteric fracture. What you rely on is compression across the fracture site. So compression against this fracture here, kind of in a perpendicular fashion. When we have our reverse obliquity fracture, we can't do that because then this screw would not be going through perpendicular to the fracture, it'd be almost parallel to it. So here's an example from the literature where they use a dynamic hip screw, and instead of compressive forces against the fracture, it results in distraction of the fracture fragments, and then it results in hardware failure. So when you see a reverse obliquity fracture, the surgeons are going to opt for intramedullary fixation. And then another feature of stability is subtrochanteric extension. So that's also something that's really important to mention. And again, that will skew the surgeon for an intramedullary rod for fixation. Okay, and which of these images shows a fracture? Or both? So we're split. So image A has the fracture, but this is super tricky, and let's take a look. So here's that subtle intertrochanteric fracture. So you really want to scrutinize for non-displaced intertrochanteric fractures. But what we see quite often is a lucency that's overlying the intertrochanteric region, and it's hard for us to tell, is this a fracture or is this a skin fold? So one way to tell is here we can see the lucency extends beyond the bone here. So it continues on in this contiguous fashion. So we're pretty confident that this is a skin fold and not an intertrochanteric fracture, where here you can see it's essentially limited to the bone. And sometimes it's very hard to tell, and if cross-sectional imaging or repositioning the skin overlying the patient can help problem solve, then those are some steps that you can suggest if you just really can't tell. And then let's look at greater trochanteric fractures. So they can be really subtle, and again, an area that you do want to scrutinize to make sure that there's not a non-displaced fracture. So here's a pretty straightforward one. But then you can see here's a non-displaced one, which is difficult to tell. And when we have that external rotation, as we see in this patient with the greater trochanter overlying the bone here, it can be really hard to tell. So say we see this greater troch fracture, what's the next step for the patient? Okay, good. All right. So let's take a look why cross-sectional imaging is, a good idea in this scenario. So here's our greater trochanteric fracture. We get a CT, we see the fracture, and then here this patient gets an MRI. And they're good to go because we don't see any other fracture. But then let's look at another patient. So here's this greater trochanteric fracture, not really displaced. Here's our CT. And let's look at this MRI. So here's our T1 in our fluid sensitive sequence, and we see this hypointense line going all the way across the intertrochanteric region to the lesser trochanter. So this is a greater trochanteric fracture with occult intertrochanteric extension. So even though this is a non-displaced intertroch fracture, we still have to address it. So in the literature, if this fracture line extends across the 50% threshold of the midline of the intertrochanteric region, they're more than likely going to go to the OR for surgical fixation. When it's less than 50%, it's really up to the surgeon of whether they want to take the patient to the OR to stabilize the hip, or if the patient's going to go on a modified weight-bearing protocol. And then I just want to advocate the use of soft tissue and narrow windows to assess the medullary bone on bony scans. I know we're used to using bone windows, but it's really important to look at the medullary bone as well. So here we have two cases with greater trochanteric fractures. Here's the fracture in this patient. Here's the fracture in this patient. So let's take a look at these intertrochanteric regions because we have our greater troch fracture. So we need to answer the question, is there occult intertrochanteric extension? Is this patient potentially going to need to go to the OR? So here we see in our medullary spaces, these are coronals through the intertrochanteric region, and here are axials through the intertrochanteric region. They look pretty similar with regards to their fatty marrow. And then let's look at this case over here. So here again are those intertrochanteric regions. This side looks pretty fatty and low density. And when we look at this side, we see that there's all this increased density here. And looking at our axial, if we look on the non-injured side, it looks pretty low in density. And then on the injured side, we see this curvilinear high density. So that should raise our suspicion that there could potentially be occult intertrochanteric extension here. And if you window it even more, it brings it out, it brings out this density more. So we look at our negative case over here, we see that medullary fat looks pretty similar. And then when we look at this side, all this density that's going to correspond to the fracture and some edema and hemorrhage, and that increased density should signal to us that there's occult intertrochanteric extension. Okay, so let's move on to some pathologic cases. So let's see if there's a fracture here. See, the answer is coming through, but I don't see it on the screen.
Yeah, I'm not seeing it on this side either, but they are
I see
showing up.
Knowing this group, I think they're all in the right spot, so I may move on. Okay. So I'm fairly confident that you guys have clicked in this region here.
Click on that little spot that says responses.
Oh, excellent. Okay, wonderful. Thank you. So I was right, and you were right that the majority of the arrows or pointers are on that correct region, which was the lesser trochanter. So I believe I have that image. So this is the case we had. So here's that avulsion fracture of the lesser trochanter. So we see this case, and then I just want to show you a young patient that still has apophyses. So we see this avulsion, and that's going to be of our iliopsoas in our 14-year-old with a sports injury where the iliopsoas kind of rips off the apophysis. But when we have a 67-year-old, we have to think differently, especially when it comes to lesser trochanteric fractures. And a lot of times these patients are not going to have a significant trauma. They'll have either a little trauma or not really any trauma at all. So when we see a lesser trochanteric fracture in someone with closed apophyses, we really have to think about why. So here is the CT of that 67-year-old, so we can see that avulsed lesser trochanteric fracture. And here we have a CT. They got a bony CT as we saw the fracture, and now we kind of narrow the windows again. So do we see anything abnormal using these windows? I'll click on responses in a second. I think that's the way to do it. I'll have a couple more come through. Okay, great. Okay, excellent. So the majority clicked on this density that we saw on these narrow windows. So here's an MRI of that density, or that that CT of the pelvis. And here's our T1 and our fluid sensitive. So this corresponds to that area everyone selected that we saw on the CT. And we can see that there's multiple areas of marrow replacement here, and even on the contralateral side. And we can see some corresponding increased signal. So this is osseous metastatic disease. And for these lesser trochanteric fractures, that's going to be pathologic until proven otherwise. The majority of that being because of an underlying osseous lesion. So again, advocating for using soft tissue and narrow windows on your bony CTs. Here we can see on the soft tissue window, we see a mass here, a mass here, and when we window it a bit more, it shows up fairly well. And this is that case corresponding to this lesser trochanteric fracture. Okay, great. Okay, so this one's subtle. This patient came in with some vague thigh pain, and this is kind of two femoral images interposed to look like one nice image. Good. So this is a tricky one. So let's see what we have on the next slide. So that image, what some picked up, again, very subtle, is some cortical beaking. So when we follow the contour of our femur, we can see that this kind of juts out a bit, and it's extremely subtle, especially in this case. So kind of a tricky case here. So what happened to this patient is we see this fracture, which looks transversely oriented in that region where we saw cortical beaking. So we saw that fracture pattern, and we saw that cortical beaking that was there prior to it fracturing. So what can we assume about this type of fracture? Excellent. So we know that this morphology of this fracture is atypical. So this is an atypical femoral fracture, and frequently we see this in the setting of patients who take anti-resorptive agents, classic one being bisphosphonates. So what that's going to do is decrease our bone resorption because they're taking that for osteoporosis, and that messes with the bone homeostasis with regards to suppressing osteoclasts. So that results in our bone becoming brittle, and that can predispose us to these atypical femoral fractures. And it's important when you see it on one side, you want to make sure that they don't have it on the other side. And they can be extremely subtle with that beaking. So here we can see the progression of this fracture. Here's where we have some subtle cortical beaking. And then here's a different patient where we see that that fracture kind of later on in its progression, where we actually see a lucent line through that cortical thickening. And then as we saw with our case, it's going to be predominantly a transversely oriented fracture with these atypical femoral fractures. And then here's an MRI of that patient prior to fracturing. So we see it's very subtle with this cortical thickening. And I actually think the edema-like signal is pretty unimpressive, but I think it's important to note that there is edema there, and that's still quite concerning for an impending fracture. So we see this little bit of edema-like signal on each side of the bone here. So even though it doesn't look impressive, this was not too long before the patient actually fractured. So it's important to be mindful that even if there's not a lot of edema-like signal, this is a classic appearance of an atypical femoral fracture and is going to be concerning for impending pathologic fracture. Okay, so just to give you some points to take home, I know we went over a lot, but we looked at our femur anatomy. We looked at intracapsular and extracapsular fractures. We went over the different types and how basicervical and intertrochanteric are treated similarly, and subcapital and transcervical are treated similarly. And we noted the concern for avascular necrosis and malunion, especially in those subcapital and transcervical fractures. We looked at how to identify these fractures, especially when they're subtle, to trace our cortices. It's important to describe displacement on our orthogonal views, and when it's more obvious on our frontal views. We looked at intertrochanteric fractures and specifically reverse obliquity fractures, how that's important because those fractures are unstable. So it's really important to look for the how the course of the fracture, and if it's reverse obliquity, to mention that in your report because that does change management. We looked at our greater troch fractures and how we have to be concerned about our greater trochanteric fractures because you can have occult intertrochanteric extension. And we went over, when you get our MRI, it's important to comment how far the fracture goes along the intertrochanteric region, because again, that can alter our management. Advocating for using soft tissue and narrow windows on your bony CTs to assess your medullary bone. It can help bring out some things that may not be apparent just on your bone windows, like here with our intertrochanteric fracture. We looked at lesser trochanteric fractures. That's pathologic until proven otherwise in the adult population. And again, advocating for using soft tissue and narrow windows because on that CT that brought about that osseous mass that we saw with our pathologic fracture here. And then we looked at our atypical femoral fractures and to look for that subtle cortical beaking, especially in patients coming in with, hip pain or thigh pain. They get an image of the femur. And if you're not seeing much, always important to scrutinize your cortices for anything subtle. And then we know that this transversely oriented morphology of the fracture is highly suggestive of an atypical subtrochanteric fracture. That's it. And thank you all very much. And if there's any questions, feel free.
Wow, thanks a bunch, Pam. That was really awesome. And so we are going to the question and answer portion. And First, I just want to point out that I really like your emphasis on the greater trochanter, what look like isolated greater trochanter fractures, and how they can be sort of a tip of the iceberg. It's not something I was taught in my residency, and it took a few cases where we ultimately found more extensive fractures, so that now I look for that, and so that's something I think for everybody to remember. Um, so one of our attendees has a question that I was actually going to ask, and so I'm gonna read that question. And so the question says, "How does your institution work up potential hip fractures from the ER? Are you using an abbreviated hip or MRI protocol?"
That's a great question. So for us right now, when we're going to MRI, we typically will do coronal and axial T1s as well as a fluid sensitive sequence. So whether it be a STIR or a T2 fat suppressed. If the patient we know is not going to, there's a chance that they may not tolerate the MRI, we try to do our coronals first. And then I know some institutions will just do coronals for these protocols. But for right now, we're doing yeah, we do kind of full field of view pelvis actually, coronals and stirs in for the workup of those fractures.
So in one of the questions that I'm just sort of interested in how different people do this, since I've been at two different institutions. So if you have, let's say, a 90-year-old falls from a standing height and they've got right-sided hip pain, and you don't see anything on the radiograph, do you just say we don't see anything? Do you add recommendations? And is there something that sort of triggers advanced imaging?
That's a great question. I think we're a bit heterogeneous in kind of how we report that. I don't think we have like strict guidelines as well. You know, we always debate, it's kind of like, do we put in something to recommend to the person who's kind of reading our report and taking care of the patient to be like, we don't see anything, but there could be something there. We really go back and forth. I think with us, probably at this stage, our ER and ortho colleagues, they know if we don't see something on radiograph, especially in, you know, that kind of patient population, that there certainly can still be a fracture. So I think we tend to not put in, you know, can obtain CT or MRI for further evaluation, but I know some people certainly do. I don't think
And
there's, you know, I don't, what do you think?
Well, so I have gotten a little more complacent lately, and just because I think the ER team does know it, that they need to be careful if they're really suspicious that they need additional imaging. We actually had a case last week that came in from primary care clinic, and so then in that instance, but it was the same scenario, fell from a standing height, and they didn't go to the ER, they went to their primary care doc. And I think in that instance, you really have to be careful not to, a family practice PA may not be as used to dealing with this as standard ER team, right?
Definitely agree. Yeah, I think it would be totally okay to suggest that there certainly can still be an occult fracture there for sure.
Yeah. I know some places actually just have like a boilerplate statement. If the patient looks osteoporotic, then they're going to put in, if there's continued concern, then recommend MRI.
Yeah.
Do you go straight to MR? It seems like you had some CTs and some MRs. Do you have like a standard pattern, or is it based on the ordering ER team, or how does that flow for y'all?
ER tends to order CTs, which I think we're okay with, you know. It's tough to know if you're gonna see the fracture on CT or not, whether to jump to MRI. And we have, you know, quite a busy neuro center. So sometimes access to MRI can be challenging. So I'm, you know, I think other people may feel differently of like, perhaps you should just jump to MRI. And I have tried to look up the cost effectiveness, and it's a little all over the place of, you know, if you get the CT because you're going to have to wait perhaps even up to 24 hours to get an MRI, depending on what's going on with the scanner and the urgencies of cases going for the MRI, then I think we're okay with getting the CT, because sometimes or a lot of the time, we see the fracture on the CT. And I think with those soft tissue windows, it can be super helpful. to at least, kind of flag it. And then perhaps if you still don't see anything, but you see kind of marrow changes on your CT, then prioritize them for MRI. But I can understand if people have, rapid access to an MRI scanner, then, perhaps that may be more cost effective for them.
I tend to recommend MRI because I do believe it's a little better. We know that probably about CT probably misses about just maybe 1% of all fractures, something in that range. So not many, but I do recommend that. But then our ER team, if they need something expeditious, like there's a scanner in the ER, and so a
Yeah.
CT scanner, and so they go with what they want, but they know what we prefer. So we got another question from the audience, and it says, I struggle with the concept of valgus impacted fracture. How can you tell if something is valgus impacted versus just impacted?
So with that, Gardner type 1, so I think it's also, you have to kind of look at what valgus and varus mean, and I understand how that can be a struggle. Um, so for the Gardner one, I think that example that we looked at is going to be your classic appearance valgus impacted fracture, and that's pretty much like the main time that you're going to see it, where you notice that the femoral head is kind of angulated outward, for lack of a better term, kind of like an ice cream on a cone. If you think about it, it's angulated outward as opposed to inward. So I find that helpful for these Gardner ones, this valgus impacted fracture. But you're going to see that pattern. That's a pretty classic appearance of the one that we saw.
Yeah, and I think one of the things that can help is if you can actually discern the primary trabecular lines, then the subcapital femoral neck fractures go right across the primary and secondary trabeculi. And so they'll be broken, and if they're angulated, then it's probably a valgus impacted. And like that's what I was taught in my residency, but honestly, like I'm eager to teach that to people, and sometimes you just can't see the trabeculi, but that can be helpful and help you know that things are valgus impacted versus just sort of impacted. And it does seem that probably one of the most important criteria really is like, is it incomplete, or does it go completely across to the medial side of the femoral neck as well? And obviously displacement.
Yeah. And yeah, those can be super hard to tell. And especially if, as you said, if they're osteoporotic and, I was going to say, I think as we were talking about before, MRI is certainly superior if, there's subtleties for questions like that. So yeah, it can be challenging.
So one final question I have, and this kind of goes back to basic technique. And, I find that certainly like major centers basically probably going to have good protocols for what radiographs, that you get in different settings. But I'm not sure that that translates to every place that everybody works. And I find that there are some places where the technologists, it's less so in the ER, but the technologists are kind of doing what they think makes sense, when whatever study gets ordered. And so if you're looking at a hip fracture and you're going to get radiographs, do you prefer dedicated coned in single view AP of the hip or of the whole pelvis when you're doing this?
I like the pelvis actually because I like to look for symmetry or asymmetry.
Mhm.
Sometimes it can be, again, as we said, challenging, and I like having kind of an internal comparison that can be helpful at times. So for us, we actually do an AP pelvis and a dedicated smaller field of view,
Mhm.
AP and an orthogonal, which is going to be our cross table laterals. So that's our standard set, which I really like because I do like having that pelvis.
Yeah.
How about
Yeah, I
you?
think it's same thing. Like I wouldn't let them do just an AP of the one side if we're actually talking about trauma.
Yeah.
You showed Shenton's line. I think it's easier to know Shenton's line is good or not if you look at the other side, and it's so much easier in peds than it is in adults to use Shenton line. And then just like the trabeculi and everything, if you have the internal comparison, I mean, nobody breaks both femoral necks at the same time. And so I think it's super helpful, and I think it's standard of care. It just doesn't percolate out to all sites.
Right.
So we're running to the end of our time. I do want to point out that the Veritas team has put a survey in the chat, and also they'll be sending out a survey after the fact. It'd be great if attendees could fill out that survey, help us know what went well and what didn't go well, and what you would like to see as far as additional topics, because we always want to respond to what our residents and fellows who are tuning in, what they want and need. And then I'd just like to thank everybody for attending. It's really been a great session. I really appreciate the great work that Dr. Walsh did and the Veritas team. As usual, puts on a really smooth show. And so again, thanks everybody for attending, and have a great night.